In today's video, we're going to take a look at the female pelvic floor anatomy. We're going to go through some of the main maternal birth trauma injuries or injuries that you would sustain during a vaginal delivery. And then we're also going to take a quick look at prolapse. So let's start by taking a little look at the female pelvic floor anatomy. So we're not going to be talking about simple terms. We're going to be looking at quite an in-depth view of the pelvic floor. So as you can see, we've got a diagram here. We have your superficial or your top layers of your muscles on this side, and then we have your deeper layers of muscles on that side there. So if we take a look at the function of the pelvic floor first and figure out what the pelvic floor is even there for, that's got two main functions: to keep things inside the body and also to allow things to come out. So we have our three sphincters. We have our urethra, we have our vaginal passage, and then we have our anal passage as well. So obviously with the urethra, we're allowing urine to leave the body. With the vaginal canal, we're allowing things to come inside to procreate. We're allowing babies to, we also want to hold the baby in through the pregnancy. And then at the end of the pregnancy, we want to allow the baby to come out. Also for menstruation, obviously, we want to allow the blood to flow out when it needs to through your cycle. And then obviously with your anal passage, we need to defecate to pass a bowel motion. So our sphincters have the function in particular of keeping things in and then knowing exactly when to allow them to come out. So that's one of the first places that you can get dysfunction or incontinence, is because the sphincters aren't doing their job. And it's not always just a muscle issue. Sometimes it's a neural pathway issue, and there might be nerve damage from a number of different things. And then the function of the pelvic floor musculature itself is not just to allow things to come in and out. It's actually trying to keep the organs inside of your body, because if your pelvic floor musculature wasn't there, we don't really have a bony structure underneath to keep organs inside. So we rely on our musculature to keep our organs inside and lift it up to their ideal anatomical place and position. So we'll have a little look at what those positions are in a little bit when we go further on into the video. But if we take a little look firstly at the superficial muscles, we have your anal sphincter here, we have your perineal body here, and then that's your vaginal passage. So we have your outer perineal muscles, and then we have your deeper perineal muscles here. So that's your deep transverse perineal muscle. And we have a group of three different muscles which work together, which most people think of as the pelvic floor muscle, but it's actually one sling of muscles that's put together. And that's like your pelvic floor hammock, which sits at the bottom of your pelvis. Your organs sit on top of that, and then your sphincters have entry and exit points throughout that musculature. So that is called the Levator ani, and it's often referred to as one muscle, but it's actually three different muscles which are separated into their own areas, which we think of as one because they work together like a hammock. And then if you take a look at the diagram here, we can see two of the Levator ani muscles here. So that's this one here, and then this one here, which is obviously wrapping around the anus. And then we have the other part of the Levator ani, which is underneath these, which comes up around and attaches to the pubic bone. And then we have our coccyx here at the back, and then we have our glute max, so the big fleshy glute muscles down here at the bottom. Now, this is another view, just in case that one's hard to see. So you have your anus down the bottom, then you have your vaginal entrance and your urethra higher up. And then we have these muscles which work like a hammock. Again, there's your pubic bone at the front, then you have your coccyx or your tailbone at the back, and they're like a sling holding everything in and then binding everything together. But as you can see, there's two sides to that sling, and we'll talk a little bit more about that soon. So with that Levator ani muscle group that I mentioned, we looked at two of those muscles there. This is the third muscle, so that's a better view. So everything in green is the Levator ani muscle groups, And then you have your pubic bone at the front, and you can see how it's split again into two sides. And then there's that little bony connective tissue structure there between the two sides. And then you have your tailbone at the back. So another view of that front muscle. So that's the front muscle that attaches to the pubic bone. It's obviously wrapping around. And then you have your anal sphincter here, or your anal passage here. And you have your vagina and your urethral passage there. So this is another view of that front muscle. And I'll tell you why we're going on about this muscle so much soon. It attaches to the bony structures of the pubic bone here, and then it wraps around the rectum and it comes back through. So this is the puborectalis muscle. So next we're going to talk about the position of the organs themselves within the pelvic floor. We'll take a little look at the male pelvic floor as well, and you'll see that they are similar, yet also the female pelvic floor is much more complex. Right, so this is the female pelvic floor in terms of the organs and how they would ideally be positioned. This woman does not have any prolapse. Everything's looking really good. Everything's in the right position there. So you have your anal passage here, and then you have your rectum. Then you have your back vaginal wall. You have your front vaginal wall. And then you have your bladder up against the side, obviously where your pubic bone is, and then up inside the vaginal canal you have your uterus, which is sitting at the top. So again, this woman does not have any prolapse. This is how everything is situated. She has pelvic floor musculature at the bottom, and then you have your three sphincters, yes, as your entry and exit points. So that's holding everything up. But then you also have these muscle tissues within the pelvic floor as well. So it's not just a base that sits at the bottom. You also have connective tissues and muscles which come up, such as the front and the back vaginal walls. So if we take a little look at the male pelvic floor and the male organs, they obviously do not have a uterus or a vaginal wall in the middle. Their rectum looks very similar. Yes, they have the anal passage, but they have their prostate here. So the prostate can get enlarged, and that's obviously a risk factor for prostate cancer. And if their prostate gets enlarged, it can impact on their bladder function and can contribute to erectile dysfunction as well. So men, in terms of the problems that they get with the pelvic floor, it's usually related to issues with urination and prostate health. And then you have a lot of men who experience pain, and that is because of tightness within the pelvic floor musculature, which women will get as well. It's just men don't often talk about it as such. But I just wanted to point out that yes, men do get problems with their pelvic floor too. Now, obviously, if we take a look at the female pelvic floor, we have more stuff inside. The uterus obviously has a lot going on within itself in terms of menstruation, growing babies, whatnot. And then as you go through pregnancy, obviously your uterus enlarges, and then you grow a baby inside. Everything is being pushed out and stretched out. There's a constant weight on your pelvic floor musculature and on your organs and on the ligaments at the top. So all of these organs are joined by ligaments up to things higher up inside of the body. And then through pregnancy, all of that weight on the ligaments is putting stress on them, and also through things like chronic coughing, excessive weightlifting, especially with poor technique, or even light weightlifting with poor technique, any exercise with poor technique actually, poor breathing mechanics. All of these things can put pressure on the ligaments, the organs, the tissues themselves, and can cause things to move. So before we talk about prolapse, we're just going to take a little look at the most common places that you would receive injury through a vaginal birth. We will go through some cesarean delivery stuff when we go through the anatomy of the abdominals, but for today, this is all about the pelvic floor itself. So we all know that we often tear through a vaginal birth, but there's different degrees of tearing, and then they're tearing in different areas respective of their degrees as well. So first degree, almost every woman will at least have a first degree tear during a vaginal birth, which is where a little bit of your vaginal mucosa is going to be torn, but everything else is kind of just left intact. You might have a little bit of grazing, but you'd be generally pretty sweet after a first degree tear. You wouldn't be in too much pain. However, a second degree tear goes a little bit deeper. So now we have perineal muscles that have been torn, and you would absolutely require a bit of stitching for this, and you'd remember having a second degree tear. Then your third degree tear comes down further yet again, and now we have a tear in the anal sphincter. So this one will be a lot harder to recover from. You have some damage to the anal sphincter, which is going to take longer to recover from. You might have problems with defecation, and then it's also a risk factor later on for issues with the back passage. Then we have your fourth degree tear, where you've torn right through the anal sphincter and right through the rectum as well. So obviously, yet again, harder to recover from, very painful. And these are the tears that we hear a lot about these, and you might have been given an episiotomy to avoid having a third or a fourth degree tear, because it's often better off for them to provide you with an episiotomy before you naturally tear through the tissues yourself, because you have a better chance of recovering with less issues in that case. Or you might have needed some sort of assisted delivery, which is a ventouse or a forceps. Some places don't use forceps anymore, and they're usually a last resort. But if you require a delivery as such, you would usually get an episiotomy. And unfortunately, the forceps themselves make you at really high risk for having prolapse and some other significant tears, which we're about to go through next, which is a tear of the Levator ani muscles. So those muscles they're obviously the main muscles, and when we refer to avulsions of the pelvic floor, and avulsion is when a muscle is torn off the insertion point, and when we're referring to vaginal deliveries and avulsions of the pelvic floor, we are, again, remember that muscle, that puborectalis muscle, which attaches to the pubic bone at the front. We are most often referring to this muscle here. So again, it's that muscle at the front there. So your avulsion, remember your pelvic floor is split into two sides. Your avulsion could be unilateral, so only on one side. It could be a partial tear or a full tear of the muscle on that side. And then you could have a bilateral avulsion where it's torn off both sides. You could have partial on one side, full on the other side. You could have full bilateral, or you could have no Levator ani tears at all. So that's where it would usually tear when we refer to a Levator ani avulsion. And the largest study that's been done has reported that up to 36% of women who have delivered vaginally will have a Levator ani muscle avulsion. So that doesn't stipulate both. It could be, if it was just a partial on one side, then that is included in the statistics as well. But as you can see, the statistics are quite high. And if going back to the forceps or assisted deliveries, that increases the likelihood of that woman having a Levator ani tear as well. So unfortunately, with this type of tear, you can't get stitches for that and just get it repaired. There's no real valid surgical fix for these tears as yet. Unfortunately, they're working on stem cell technology, but that is still quite a fair way away. And one of the top leaders in the field who has been studying the repair for this for as long as anyone has, because they only started really figuring out about these muscles in the last 7 or 8 years. So if you're sitting there thinking, oh, I've never been told about that, they only started to figure this stuff out in the last decade. So it's still relatively new. How do you know if you have a tear of the Levator ani? So some of the telltale signs are you do your Kegels until the cows come home and you don't feel like you're gaining much strength. You feel like you don't have much strength in the pelvic floor itself, whether you do Kegels or not. If you feel along where the pubic bone is, you might feel like there is some muscle or some tissues missing there. But the only real way to get a proper diagnosis of whether you have avulsions of the levator ani muscles or not is to go through, depending on your country, in New Zealand here, you have to go through a specialist to get a 3D transperineal ultrasound. And through this high-tech imaging, they will be able to take an in-depth look of your pelvic floor musculature. They will be able to tell whether you have any avulsions to the muscle here, the puborectalis or levator ani muscle avulsions. Another symptom of that is feeling like you have quite a wide vagina, or we call it a hiatus inside. So if you feel like you're quite spacious in there, you also could have it's possible that you have levator ani muscle avulsions. So obviously that's going to impact the function and health of the pelvic floor quite significantly, and like I said, there's no surgical fix for this at this point, but you can go through and try to strengthen up the rest of the pelvic floor musculature the best that you can, in order to, and get all your other ducks in a row, your breathing, your training, how you train, what you train, etc. Everything should be, you should be doing the best that you can, because you can't get that surgically repaired. The other place that you can avulse, generally with your vaginal bursts, which we haven't covered, and they aren't on here because these are the tears that most people know about. We've talked about the anal sphincter, is your deep transverse perineal muscle. So that's a big muscle. If you look at that, that's that muscle there. So these muscles are often torn through vaginal deliveries as well. And again, these are often missed, but back to that 3D transperineal ultrasound series, that can also pick that up. There is, however, a surgical fix for that. So, considering all of these things, when we take a look at those pelvic floor muscles, we have our uterus there, we grow a baby, the baby comes through. The act of vaginal childbirth is, I know they call it natural childbirth. Is it natural? I don't know. It has like a large baby coming through such a small opening. It doesn't seem natural to me. And if you've ever done it, you're sitting there going, yeah, it doesn't feel that natural to me. Anyhow, it's got to come through that small opening. It's got to pass through this musculature, yeah? So your pelvic floor muscles during a vaginal delivery, while our hormones and everything have set ourselves up so that our pelvis can expand to allow our baby to pass through, your pelvic floor muscles will stretch by 1.5 to 3 times their resting length in order to pass your baby through. So that's like taking your bicep muscle, and if you're standing, taking the bottom of your bicep and stretching it all the way down to your ankle and expecting it not to tear or have any sort of long-term repercussions from that act. It might be a short act, but the damage done to that muscle is still pretty significant. So you really have to take your time to rehabilitate from the inside out in order to get the best return to health through that muscle as you can. So pretty significant act, really. Nothing natural. It's more like it's superhuman. They should call it a superhuman birth. And then we're going to talk about prolapse. So considering everything that can happen through a vaginal birth, you can see why a vaginal birth is a significant risk factor for pelvic organ prolapse. And if you don't know what that is, I'm about to show you. So again, we have our organs here, all in their lovely anatomical position. Everything's looking really, really good. And then you go along and you have a baby, and they might not, or they most likely would not, at least straight away, they're not going to be in the same position anymore. Okay, your uterus itself is going to be a little bit lower, and you might have moved your organs down. You might have some, obviously remember your vaginal walls have been stretched by 1.5 to 3 times their resting length, so they're going to be what we call lax. So you're going to have vaginal laxity, and then with that your pelvic organs can start to shift down. Remember those ligaments that were up there, they've also been under strain under a really, really long time. So they might not be as springy and bouncy as they once were. They might be a little bit stretched. and they've been under stress for a while. And then after you have the baby and you're breastfeeding, you still have a lot of those pregnancy hormones surging through your body. So you don't just return back to your normal self right after the baby is out anyway. And the hormone relaxin will take a while to come out of your system, which literally relaxes all of your tissues and ligaments in order for the baby to grow inside your body and to come through. So what can happen is we can have our organs shift, or our vaginal walls can become lax and stretched. We have what's called fascia through those vaginal walls as well, and that fascia can get obviously stretched. It can also get torn, and it can take a long time to get back to your pre-baby self, and a lot of women won't ever go that way as well. So let's take a little look at a few types of prolapse that can happen. Again, okay, so we have our normal anatomy here. Yeah, you got your front vaginal wall, bladder. So the first type of prolapse that we'll look at is a bladder prolapse, or a front vaginal wall prolapse, or a cystocele. So this is where your bladder, which would normally sit like so, it might be that your vaginal wall has just gotten a little bit too lax and stretched, and then your bladder is now protruding through the front vaginal wall. So it's bulging into the front vaginal wall. And then your bladder can have that sac which hangs down here, which can create pressure, problems with urination, etc. Then we have a back vaginal wall prolapse, or a prolapse of the rectum into the back vaginal wall. So this is called a rectocele. So obviously with that, we have our rectum, which is normally up nice and high here. We have a sagging of the rectum down into the back vaginal wall, and then you have that little sac which can collect stool, and you can have problems with bowel movements and defecation. And obviously all of these types of prolapses can cause issues with incontinence as well. And then we have a uterine prolapse. So uterus, usually up nice and high, right up at the top of the vaginal canal. It might be again that the vaginal walls are loose. It could be that the ligaments which hold these organs, usually up here, have been damaged. It could be a mix of both, but the organ is descending down. So that is what a prolapse is. So this is a uterine prolapse. And then we also have, but wait, there's more. My gosh. So hard to be a woman, isn't it? This is the anatomy of a female who has had a hysterectomy. So she has had her uterus removed for whatever reason, and she now has a vaginal cuff, which is again structured up by sutures, but for whatever reason this vaginal vault or vaginal walls, the vagina is now prolapsing down. So this is a vaginal vault prolapse, where the vaginal walls, the front wall and the back wall and the cuff as well, is starting to come down, descend down. Then, but wait, there's more. Oh my gosh. We have your small intestines, which can also prolapse. So with here, with this picture here, sorry, she obviously still has the uterus, but this type of prolapse can happen alongside this vaginal vault prolapse as well. So that's where the vault can come down, and then the small intestines can come down with it as well. So as you can see, a lot can happen. There are a lot of things that can move and shift around. A lot of the time women will be able to improve the positioning and the health of their pelvic floor through one, education, and then changing lifestyle habits, and then implementing a prolapse friendly or a pelvic floor friendly exercise regime. How do you know if you have a prolapse as well? You'd usually have some, not always, but you'd often have some sort of symptoms. So it could be heaviness, you could have pain, you could have problems urinating, defecating, you could have incontinence, you could have just a feeling like something's falling out. A big one is a feeling of a stuck tampon or a golf ball just inside your pelvis that you can't seem to shift. And you can get a diagnosis of a prolapse by seeing your general practitioner. You can have a feel around yourself and you might be able to figure it out yourself, but the best place to go is absolutely a pelvic floor physical therapist or a pelvic floor physio. So they will do an internal examination on you, and you can also go to a specialist like a urogynecologist who can again order those 3D transperineal ultrasounds, and they can give you a really in-depth diagnosis of the state of your pelvic floor. So as you can see, there's a lot that can happen to a woman who has delivered vaginally, but it doesn't necessarily mean that these are exclusive only to those women. So women who have never had a vaginal birth, it doesn't even matter if you have never even had a pregnancy, they can absolutely, usually not an avulsion, but they would have, they could have issues with prolapse from excessive coughing. Connective tissue disorders is a big one. Menopause, because you lose that connective tissue structure becomes weaker through menopause as we age. Yeah, so a lot can happen. Now, digest that information, and hopefully that visualization of the pelvic floor, it's just starting to rain, will help you when you're doing your Kegels, and just understanding a little bit more about why there is such an importance to look after your pelvic floor health, not only now, because you might not have any issues now, but you could have issues later, and menopause is a classic time where women start to encounter problems with their pelvic floor. So if you can get all of your ducks in a row before that point, then you will be in a better position going into menopause. Our next video, we will go through the anatomy of the abdominals, and we will look at some of the things that happen, or some of the tissues that they go through to deliver via cesarean section, and some of the complications that these women have after trying to recover from a cesarean section long term as well. So I hope to see you then, and if you want to share this video around, please by all means go for it.